Good morning, everyone. Morning. I'm Dr. Makwela. We're presenting from the Department of Neurology. Our title this morning is How to Choose an Anti-Epileptic Drug. We see this topic as being fitting, mainly because of how resource limited we are in the country, not only just in having the proper health buildings and health infrastructure, but we know how a whole lot of epileptic patients in this country will never ever get to see a neurologist. So it's very much fitting that any doctor at MBCHB level or even specialized knows how to, or the basics at least of how to approach this topic when faced with an epileptic patient. So our speaker this morning, Dr. Sujay Surendran-Nair. He's a third-year neurology registrar, very charismatic. Look for him, please, on social media. He already knows he has special interest in epilepsy and vascular neurology and digital media education. He's very big in that space. So yes, please, thank you.
Thank you. All right, good morning, everyone. How are you? All right, so as mentioned, today we're going to be talking about how to choose an anti-epileptic medication. So for the purpose of the talk, I mean, it's obviously quite a vast topic and there's a lot to talk about and to cover in under, at least 40 minutes. But I think what we want to do is try and tailor it to our South African setting. And instead of going through every, single medication, actually just look at general principles to consider when you're choosing the anti-epileptic medication as well. And I mean, I chose to keep it as anti-epileptic drug because we're all familiar with the terminology, but going forward, the updated nomenclature now is anti-seizure medication, according to the International League Against Epilepsy. So I'll be using that term in the rest of the slides as well. Yeah, there we go. Okay. All right, just to touch on in South Africa, still very relevant for us as well. I mean, epilepsy is still a significant neurological condition affecting about 1% of the general population. And what you don't expect is actually the higher burden is actually in the rural areas. This is also because things are picked up much later. And usually by the time patients present an active convulsive epilepsy, some of the stats show that 7 in 1,000 individuals are actually being diagnosed with epilepsy. So it does highlight this disproportionate burden in underserved areas and highlights the fact that because this is the population we are seeing more of, it really emphasizes the importance of choosing the right adequate seizure medication, because a lot of these patients might also be going to the local clinics before they're being referred to us. So it's up to us to also make sure that they're on the right treatment. And oftentimes you'll come across a similar scenario. A young woman, let's say Sarah, for example, presents with a generalized tonic-clonic seizure at work lasting about 2 minutes. And it's now the second one. The previous one happened last year. Has post-seizure, she has confusion with post-ictal amnesia and fatigue. But neurologically, oftentimes by the time they present, they can be normal. If we catch it early enough, then the EEG can be abnormal. And then this is perhaps not as apt for our setting, but ideally you would have an MRI proving no structural abnormalities. But if you come across that situation, then the big thing to consider is what will you do next? And some of these principles that I'll highlight further with a little quiz at the end. So hopefully people are paying attention. I just put a slide here because this is now the updated International League Against Epilepsy classification. So before we used to call things, generalized seizures, focal seizures, but in focal we say simple focal seizures or complex partial seizures, a different terminology. Nowadays, it's all updated to focal onset, generalized onset, or unknown onset. And then the focal onset is further now subdivided into focal impaired awareness or focal intact awareness. So intact awareness is now the previous simple partial seizures that we were talking about. And then you could further subdivide into motor and non-motor. They go into further detail, but I'm not going to go into too much detail on this, but I just added this because when you're choosing the perfect anti-seizure medication, the type of epilepsy that actually the patient presents with obviously plays a huge role. And that's the first and foremost, most important thing to consider. So once you come to a diagnosis about the type of seizure, then you can then choose the appropriate anti-epileptic or anti-seizure medication for your patients. So if you had to then, after diagnosing the particular syndrome or the epilepsy syndrome, how would you then choose the perfect anti-seizure medication? So in any setting, if you had to sort of design the perfect anti-seizure medication, the most important thing you'd want to consider are these general principles. So you'd want something that's ideally broad spectrum, right? Because you want something that you can use on a wide variety of patients. And naturally, you want something that is high in efficacy, but low in drug interactions, with favorable, big factor being the pharmacokinetics need to be ideal, that you could use this medication on many patients with the least amount of side effects. You ideally don't want to have too many cumbersome lab tests to monitor it. You don't want medications that you can develop a tolerance to. That's why benzodiazepines, we don't use in the long term, rather only in the short term. And naturally, you want something with the less side effects as well. But a big thing in our setting is the cost. So, I mean, we know that the newer medications that we're using in states today with lamotrigine and Keppra work really well, but the big factor is cost. And that's why, as you'll see in the coming slides, things like phenytoin and valproate are still very effective, and they're still very useful, and they're easy to access. So that's why it's still very useful in our setting. And then formulations play a big role, that you'll see, because you don't want something where you're asking a patient who's struggling with seizures to now be taking a medication 3 times a day, 4 times a day. So ideally, something that is a formulation that is used as a principle either once or twice a day is most ideal. This is just summarizing sort of where we are in terms of anti-seizure medications. So one of the earliest ones that we hardly use now in adult populations is phenobarb, way back almost more than 100 years ago. But phenytoin was one of the earliest discovered medications. And then that was part of the first generation, but they didn't fulfill all these characteristics that I mentioned in the previous slide. And so once they improved on all those factors to try and get a better anti-epileptic medication, a second generation boom happened in the late 1970s and 80s. And that's where you start seeing the more common ones that we are starting to use today, especially valproic acid coming out to being much more popular at that stage. And then now the third generation of medications in the late 90s and early 2000s or 2010s are the ones that are now taking the basically precedence, especially in the private sector, but in our setting, it's becoming more and more available as well. So levetiracetam, lamotrigine, lacosamide gaining in popularity now as well. These are medications that are fitting into a third generation because now they have much less of this, the side effects with much more favorable profiles and easier for patients to take. So when you're looking at how to choose the right anti-epileptic, there are basically 2 things to consider as medication-related factors and patient-related factors. So if you had to zoom in a bit further onto medication-related factors, you could think about 7 basic principles, right? So you want to first consider the mechanism of action, the spectrum of efficacy, or actually the seizure type. Is it going to be effective for that particular seizure type? Big one is going to be pharmacokinetics. Another one would be then part of pharmacokinetics as well would be drug interactions, and then tolerability, safety of the medications, the formulation, and cost. So zooming in further on the mechanism of action I think obviously we can't go into all the mechanism of actions of every single anti-epileptic for this talk, but here's a nice slide just summarizing the most important things to consider. Generally we know epilepsy as a condition where there's abnormal overexcitation of neurons, or in a very simplified term, decreased inhibition of the postsynaptic neurons. It's either one or the other, where you have too much irritability and excitability of the neurons, causing epilepsy and seizure disorders. So right at the top there, on the presynaptic neuron, sodium channel blockers, voltage-gated sodium channel blockers, once they get depolarized, that opens up to be the first step in this whole process of stimulating downstream. So once that sodium channel blocker opens up, it stimulates the release of these voltage-gated calcium channel blockers, and that then stimulates the release of the action of these vesicles, the synaptic CV SV2A vesicles to release neurotransmitters into the synapse. And then depending if the postsynaptic is either an excitatory or inhibitory neuron, if it's an excitatory neuron, it works on 3 different channels, the calcium channels on the postsynaptics, NMDAs, postsynaptic neuron, and AMPA. Or if it's an inhibitory synapse, then it works on GABA receptors. So if you go all the way back to the top there, that's where the bulk of the anti-epileptics work. So, I mean, most of the anti-epileptic medications go straight to that first step right here, where they stop that whole process from happening. Excuse me. So valproate, phenytoin, carbamazepine, lamotrigine, topiramate all work on that first aspect there. Further down, they've also now discovered medications that can block the calcium channel blockers to prevent the rest of these steps from occurring. We don't often use it as much now in epilepsy, but now pregabalin and gabapentin, as we know, Lyrica, is now used in neuropathic pain. But the principle still applies. It's to do with the irritability of the nerves and decreasing that irritability. Then one of the big ones that has helped us a lot nowadays is Keppra or levetiracetam, and that actually works on blocking these vesicles from stimulating the release of the neurotransmitters into the synapse. And then if it's on the excitatory postsynaptic neuron, then there's a medication called ethosuximide. We don't see it as often because it's a very specific medication for a very specific seizure disorder, specifically absence seizure disorders. But if you do have a patient that presents with absence seizure disorders, the postsynaptic calcium channel blockers, ethosuximide is the most appropriate one in this situation. And then ketamine works by blocking these postsynaptic NMDA receptors, but valproate also plays a role. So it's another thing to highlight why valproate is still very useful, because it has both presynaptic and postsynaptic effects. And then AMPA, that's where topiramate comes in. And topiramate in our setting seems to be a bit underutilized, even though the side effect profile isn't too bad nowadays. And it actually is something that we are trying to push more for, so that we can get more patients on topiramate. It is easier to get than Keppra as well, especially because it also seems to have a dual effect. So in our setting, practically always think about topiramate as well. We'll highlight specific conditions why you can also think about topiramate in coming slides. And then if the postsynaptic neuron was inhibitory, then that's where the GABA receptors are then stimulated. So you can actually further subdivide into GABA A or GABA B. And if the GABA A receptors are stimulated, that's where the older medications of phenobarbital is actually working on GABA B. And then GABA A is where GABA B is where benzodiazepine. So just think benzo, like Ben or B. That's an easy way to remember it. And that basically keeps the GABA channels open more frequently. The GABA channels are open, whereas GABA A is where the GABA channels are open for longer. But basically, the net effect is that you have increased inhibition and decreased excitability of the nerves. But it's just something to consider when you're choosing these medications, because once you then tailor it to the type of epilepsy that the patient has, then it becomes a lot more relevant. Generally, we want to divide medications into first line or second line based on availability and based on side effect profiles as well. But again, you can see why even according to the international standards, valproate is still deemed first line. So we can still use valproate often, and usefully it works quite well. Ethosuximide, tailored just for absence seizures, is more specific. Lamotrigine is good, but lamotrigine you have to be quite careful with. We'll highlight why in the coming slides. And then this is one of the things I just wanted to highlight. Carbamazepine is gaining in popularity as well nowadays. But one thing to consider where you have to be cognizant of the type of seizure disorder the patient's having is because of the way it works. Carbamazepine has actually, based on the recent studies, been shown to worsen myoclonic generalized epilepsy or absence seizures. It's a very important thing to keep in mind when you're choosing your anti-epileptic medications. It works really well for focal seizures. But again, in our setting, if a patient's taking ARVs, for example, because it's a potent hepatotoxic, or hepatic enzyme inducer, you want to be careful with carbamazepine in those settings. And then second line is where we still go to medications like Keppra. We don't really use clobazam as much. And then focal seizures, you can still use valproate and topiramate, but carbamazepine or lamotrigine is still good for use in those situations. Highlighted some of these already. But, there's all sorts of pediatric populations that they come with specific epilepsy syndromes. Don't want to go into too much detail onto these ones because it's just basically showing how you can still, you have specific syndromes that have been shown to respond better to specific medication things. So it's just highlighting why the specific syndromes play a role in choosing, or the principle of choosing your anti-epileptic. For example, Lennox-Gastaut is quite a treatment-resistant syndrome. And thankfully now the more recent studies have started to show better effects with lamotrigine and topiramate as well. But what happens if you have a situation which we often face where you don't really know the epilepsy type? Because oftentimes you get a patient and you're not sure about the history, you're not sure what type of seizure they had, and it's difficult to choose. So that's where you look for more broad spectrum anti-seizure medications in those patients. Specifically in our setting, valproate then again becomes useful. But nowadays, lamotrigine and levetiracetam is more popular. Now, levetiracetam and valproate work a lot faster. Lamotrigine, the problem is that you have to titrate it up very slowly, so you might not get immediate effect. So that's why it goes back to showing why valproate and nowadays, if you have access to it, Keppra are very useful in the initial setting when you don't know what the seizure type is. So now we come to the pharmacokinetic consideration. So ideally, you'd want a medication that is absorbed completely with linear kinetics, not something that is metabolized too quickly or too slowly, quite linear kinetics with a long elimination half-life. That allows you for once daily dosages or BD dosages. And then something that is not so much affected as much by protein binding. So the lower the protein binding, the less it is vulnerable to changes in protein states in the body. And then you have to keep in mind the kidney and the renal function, the kidney and the liver function of the patients. But ideally, we have a tendency where we can get a bit impatient and put patients on polytherapy just because we want to get seizure control as quickly as possible. But this really opens you up to a lot more trouble because that increases the likelihood of drug interactions, increases the likelihood of poor efficacy of one medication versus the other. So where possible, still try for monotherapy. Now at the bottom of the slide there, the big thing to consider are your hepatic enzyme inducers and inhibitors, which is big in anti-epileptic or anti-seizure medications. Out of that, carbamazepine is the most potent cytochrome P450 enzyme inducer. So whenever you're using Tegretol or carbamazepine in a patient, be very careful about the medications that are metabolized through the liver, especially in our setting where we have patients on TB medications, we have antiretrovirals, some of our childbearing potential females are on oral contraceptives. Be very careful when they're on Tegretol because it might decrease the efficacy and reduce the efficacy of the other drugs. There's a slide here just highlighting the other ones, carbamazepine being the biggest one, but phenytoin as well. And then inhibitors, cytochrome P450 inhibitors, valproate, can actually increase the concentration of medications that are metabolized by the liver. And one big thing to consider is lamotrigine being more commonly used. Lamotrigine is still metabolized in the liver. And that's why things like Keppra become more useful in patients with hepatotoxicity, because this undergoes renal elimination. So in a patient with hepatotoxicity where you want to use an alternative anti-epileptic, if you have access to it, levetiracetam or Keppra becomes a lot more useful. I included the slide because we've seen more and more patients that are started on both sodium valproate and lamotrigine in our setting. While that is a good concept, because a lot of the women that we identify as being of childbearing age, we want to wean them off valproate because of the teratogenic effects. One thing to keep in mind though when you're weaning off these patients is that Epilim, as mentioned in the previous slide, is a cytochrome P450 inhibitor. So it inhibits the glucuronidation of lamotrigine in the liver. So this actually leads to increased effective levels of lamotrigine in the system. So a general way to think about it is you're basically doubling the dose of lamotrigine. So you have to be very careful when you're titrating up lamotrigine in these patients. So most of the time, if patients are on monotherapy, you could start them on, for example, 25 milligrams BD if they were not on any other medications or if they were not on Epilim. But if they were, for example, on Epilim or valproate, you'd rather want to start them on 12.5 at a 12-hourly dose. because of the fact that you're basically effectively giving them 25 BD. We know that now lamotrigine is one of the highest risks for developing skin-related drug reactions in all the anti-epileptics. So Stevens-Johnson's being the most devastating of that. And therefore, just keep in mind that you always want to start lamotrigine at half the dose that you usually would have in these patients. So that's a big thing to keep in mind on these patients. The other thing is, I mean, these are many different considerations on the pharmacokinetics, but if I just again go to the protein binding aspect of the medications, I mean, many of the medications, unfortunately, the way they're designed is that they are, you know, especially the older generation medications like phenytoin, valproate, and the benzodiazepine medications are highly bound to protein. And so in our setting, where you have situations where, you know, we have so many patients that are immunocompromised, or there's high evidence of malnutrition in our populations, usually you have a high index of suspicion for these patients to have hypoalbuminemia, and if you test for it, they usually have low protein. So that's a big factor to consider, because any small drop in the albumin levels in these patients can actually significantly increase the concentrations of these medications. So when you think about it, medications that have a narrow therapeutic index, like phenytoin, for example, you effectively are increasing the levels, the effective concentrations of the levels of phenytoin. So we can have situations where patients, you can test their phenytoin levels, but if they have hypoalbuminemia, the level on the blood might return as normal, you know, within 10 to 12, within the 10 to 20 range. But effectively, the actual dosage of although the concentration of the phenytoin might be much higher. So it's still something to keep in the back of your head. If you have a patient where you're suspecting, you know, for example, in phenytoin toxicity, if they've got any sort of ataxia or increased drowsiness or anything that you're suspecting might lead to drug-related toxicity, and the levels are coming back normal, make sure that the albumin is also normal. There is actually a specific formula, like it's basically just a formula that you can use in these settings. So you basically look at the phenytoin observed in the blood, the actual measured albumin level times 0.1 plus 0.1, and then that gives you the corrected one. So for example, here, the observed phenytoin level that they had received in the blood was 9. But once you factor in the fact that they had such a low albumin level, the effective dosage or the effective concentration is actually 36. So it's actually much higher. And they might actually be toxic without you realizing it. So it's something big to consider in our setting, especially because hypoalbuminemia is quite prevalent. And then, of course, the tolerability and safeties, you know, it speaks for itself. Medication intolerance, a lot of the patients sometimes just don't tolerate. We've had patients who do really well on Keppra and other patients who hate Keppra, even though, you know, they talk about Keppra being one of the best side effect profile medications that we have. So that really is tailored to the patients. And it depends on the many other factors, which we'll cover in more related to the patient-related factors when you're thinking about these considerations. And then the aromatic anti-seizure medication group, this is basically carbamazepine, lamotrigine, phenytoin in our setting. They're the ones who are more likely to cause skin reactions. And as touched before, the lamotrigine is the highest risk. The one thing to consider here is that if you've got a patient who's already had a reaction to lamotrigine, for example, you don't want to start them then on carbamazepine, because there is cross-reactivity with other aromatic anti-seizure medications. So keep that in mind when you're taking their drug history or what medications they've used in the past. And then genetics obviously will play a huge role. The HLA, you know, we don't do it as much in our setting, but overseas they actually do HLA subtyping to measure the sensitivity to drug reactions as well. And then obviously formulation, we've touched on the lower you need to dose, the less frequently you need to dose, the better. And then the lower the cost, the better in our setting. So now coming to patient-related factors, the other 7 things to consider is the age of the patient, the gender of the patient. Pregnancy should be a factor considered on its own. The race, etiology of the actual cause of what's causing the seizure, comorbidities, and of course, something that we forget about is patient choice. So in age-related factors, the older patients obviously will have a lot more comorbidities, more likely to have more comorbidities, and therefore higher risk of polypharmacy. So it's just something to keep at the back of your head because they're more likely to be on medications that could interfere or interact with the anti-seizure medications. So again, looking for medications that are not as hepatic enzyme inducing or inhibiting is probably more ideal. So that's why, again, going to medications like carbamazepine and valproate, for example, interferes too potently with the hepatic metabolism, and you want to try and avoid those medications in the elderly population. You want to use the lowest effective dose in general for the elderly population, as with any consideration for geriatrics in general. And therefore, lamotrigine and levetiracetam or Keppra are the most favored in the elderly population, out of which, if you have access to it, once again, Keppra is the most superiorly tolerated medication in the elderly population. But now the big one that you have to consider is gender. So females are obviously a big thing to consider, especially females of childbearing age, because they are high, especially in our setting, they're highly likely to be on oral contraceptive as well. So as touched on in the previous slides, any sort of enzyme-inducing medications, be careful of contraceptive failure and warn them about contraceptive failure and the chances of that in these situations. The estrogen and progesterone on their own actually have specific effects on the seizure threshold, but I'll come to that in the coming slides. I just wanted to highlight something at the bottom here where nowadays the latest guidelines actually recommends that all women of childbearing age automatically or be started on folate supplementation. It's not just on valproate, it's not just on phenytoin. Any woman on folate supplementation should actually be now preferably started on folic acid supplementation. And all women, even if they are not pregnant, but if they are of childbearing age, we know that folic acid still plays a role even in the development, obviously in the first trimester. Some women fall pregnant without knowing that they're pregnant, so it's now generally recommended that where possible you can start supplementing women with folate early on as a preventative measure. Now, pregnancy on its own, valproic acid. Now, firstly, I'll probably start off by saying all anti-epileptic or all anti-seizure medications have teratogenic effects. So it's not that one doesn't or one has more, but this is a spectrum. So the medication that we know of and that's most well documented to have the highest risk of teratogenicity is valproic acid. But all of these medications can, but the most well tolerated and the least likely are the two L's, so levetiracetam and lamotrigine. So if you had to now come across somebody who's either planning on conceiving a child or is already pregnant, lamotrigine and levetiracetam is still the best agents. It's just to keep in mind that it's not zero, it's not zero risk. But ideally, especially in the first trimester, you want to be before, if it's a planned pregnancy, especially by this stage, you want to have already weaned off the valproic acid and either increased Keppra or lamotrigine in these patients. Polytherapy is a big risk in pregnancy because using 2 or more anti-seizure medications obviously increases the risk of congenital malformations, and up to 1.6 times more. So where possible, again, the principle still of monotherapy is still relevant for pregnancy. Doesn't mean that now, that's why it's ideal that, it has to be a planned pregnancy, because then you could already wean them off the valproate before they are being started on the lamotrigine, before the lamotrigine is reaching like a therapeutic level. And then interestingly, it's not just about during the pregnancy or the development of the baby with the high risk of neural tube defects being one of the risk factors with anti-epileptic or anti-seizure medications in pregnancy. Now, a lot of the newer studies have also shown that valproate exposure has been associated with increased risks of neurodevelopmental disorders. So autism spectrum disorder, ADHD, intellectual disabilities are now on the rise and thought to be also related to valproate exposure, or some of the older ones such as phenytoin and carbamazepine. I'm not sure how many people, I'm sure some people in the room here received the circular I think it was last year, last year sometime from Sanofi, where they've actually now found that on a recent study done in the 3 European countries, based on the registry that they had there and the follow-up after that in terms of neurodevelopmental disorder, what they did is they looked at the children who were born to men who were treated with valproate within 3 months prior to conception and at the time of conception as well. And what they found is that there is actually an increased risk of neurodevelopmental disorders, basically up to 4 to 5.6% as well in children. So this was a circular that was sent out just to exercise caution that nowadays even men who, especially if they come in and they tell you that they're planning pregnancy in the next 6 months or 3 months, you want to change men off valproate as well, because that's now also a significant risk factor for the baby as well. So it's one of the newer things that have come out. And I thought this was quite interesting and an easy way to remember it specifically for obstetrics and just for women of childbearing age in general. Estrogen on its own is epileptogenic. It's a pro-seizure hormone, and progesterone, you can think of it as anti-seizure, or progesterone's protective. Okay, just think P for P. Progesterone's protective, and that's because estrogen actually increases neuronal excitability, so enhances glutamate release, inhibits GABA, and therefore reduces your seizure threshold and worsens. We often have patients in our clinic that will tell you in the first half of their period cycle, their seizures worsen, and this is what we call catamenial epilepsy right there. Usually for these patients, you could consider either giving them a short course of benzodiazepines in that first half of their menstrual cycle, and it works quite well, and it's because of the short duration of the action, it's quite ideal for these patients. But in our female population where they really struggle with catamenial epilepsy, they have even considered progesterone therapy in select cases. But in pregnancy itself, pregnancy on its own, based purely on the progesterone effects, is actually protective, because you have a rise in both the estrogen and progesterone in pregnancy, but you have a disproportionately much higher rise in the progesterone. So the overall net effect is that you still have a neuroprotective effect because of the progesterone when somebody's pregnant. Now, obviously, we come across preeclampsia and eclampsia, but that's separate to this. That's actually a separate disorder. Preeclampsia is an endothelial dysfunction, inflammatory disorder. And because it's an inflammatory disorder, it disrupts the blood-brain barrier and causes basically increased oxidization and free radical damage onto the neurons. So that's what causes neuronal excitability and worsens seizures in preeclampsia and eclampsia. But if an uncomplicated pregnancy exists, then actually progesterone is more protective. Just touched on this. We actually touched on the previous slide, but the specifics, racial considerations to take in mind is the Han Chinese population has now been documented to have HLA-B alleles that are linked with a much higher risk of Stevens-Johnson syndrome. So obviously in our setting, it's maybe not as relevant at this current stage because we don't have access to this testing, but overseas, what they usually do is they actually test for the HLA-B gene if this patient is from the Chinese population or Asian population, and they can actually test the risk of lamotrigine. So if they're negative for this, then it's a bit safer to start these patients on lamotrigine. So it's now actually a recommendation overseas for anyone being started on an aromatic one, which is basically lamotrigine, carbamazepine, or phenytoin. You want to do HLA testing for these patients. And then, of course, the specific etiology to consider. So we're starting to see a much higher rise in autoimmune encephalitis in patients. And early initiation of immunotherapy is by far the most important thing. And more than the seizure medications, immunotherapy then becomes more important. But if you are choosing a seizure medicine, then sodium channel blockers, because of how often the specific autoimmune receptors that are actually involved, sodium channel blockers actually have the best effect on these conditions. And then specific etiologies to consider: Alzheimer's disease, which we see obviously a lot more of in neurology, they respond better to levetiracetam based on the latest research. Stroke patients also, if you can, lamotrigine or levetiracetam is much better tolerated. And then something we actually get consulted on quite often is we have a lot of patients on anticoagulation for other conditions. So in these specific considerations, you want to avoid enzyme-inducing anti-seizure medications as well, because obviously the anticoagulants are being metabolized by the liver. So if you have something that's now increasing the drug clearance, you basically effectively worsening the effective dose of that medication. So potent enzyme inducers like carbamazepine and phenytoin should be avoided with the actually both the direct anticoagulants and the vitamin B antagonists. So you rather use lamotrigine or levetiracetam if you can in those situations. And then coming to comorbidities, we've actually touched on this already with regards to avoiding enzyme-inducing ones, even on immunosuppressive therapy. But, obesity is also a consideration. So in some cases where you have a proper discussion with your patients, one of the few anti-seizure medications that have weight loss as a side effect is topiramate. And if they do tolerate it well, then topiramate might be a preferred anti-seizure medication in these patients because it might actually assist them with their weight loss as well. You want to avoid weight gain inducing anti-seizure medications such as valproate, and some of them maybe on Lyrica, for example. And then the common theme that seems to come out of this whole talk is that, use Keppra where you can. But the one time where you do not want to use Keppra or levetiracetam is any patient with pre-existing psychiatric illness. So the most potent the most potent effect of levetiracetam is that it can actually worsen suicidality in these patients, especially in patients with major depressive disorder, to the point where it's now even highlighted on the boxes as one of the main things to consider for patients with psychiatric illness. So the one time you don't want to use levetiracetam or Keppra is if you're called to the psych ward, basically, or if you get a patient who's got coexisting major depressive disorder, rather avoid Keppra where you can. That's where lamotrigine comes into play. It's being used even in psychiatry more often now as a mood stabilizer. It's got mood stabilizing effects and it's got strong anti-seizure effects. It's much better to be used in the setting of a patient with comorbid psychiatric illnesses. This is just this table summarizing all of those. And then the big factor to always consider is patient choice. Always have the discussion with the patient, always talk about the pros and cons. The more well-informed the patient is, the more likely they're going to take those medications and interact with you in the follow-up visits to tell you about what are the side effect profiles, what works for them, what doesn't work for them. Really, it does depend on each and every single patient, and there is no one size fits all. So always remember to keep that in mind. I mean, I'm not going to go through this, but this is obviously for anyone who needs reference on that. I just touched on this as a matter of interest that epilepsy is now, we're looking at epilepsy more as a network disorder that can basically using EEG monitoring and machine learning together with, with the advent of artificial intelligence, we're now actually using EEGs with artificial intelligence to predict the seizure patterns in a lot of the patients. And based on those seizure patterns, you can actually then tailor-make your anti-seizure medication for that particular seizure disorder. So it's just something to keep an eye on for the future. But I thought maybe we could have 2 or 3 quizzes, maybe, just to sort of recap what we talked about. So I'll open it up to the floor or even anyone on Zoom. So in a setting where you have a patient, simple question, woman of childbearing potential, which anti-epileptic medication would you consider safest for use in a woman of childbearing? Would it be lamotrigine, valproate, phenytoin, or carbamazepine? 2. All right. So as we know, we touched on lamotrigine as the least. Yeah, I actually said it first. So in patients with depression or anxiety, which anti-epileptic should be avoided? 2 as well. So Keppra is the one thing we touched on that we want to avoid. In patients in Asian ancestry, especially with the HLA allele, which drug is most likely to cause the Stevens-Johnson syndrome? Well, there we go. Because it's part of the aromatic group. So a bit more to think of. 40-year-old gentleman, HIV positive, newly diagnosed TB meningitis, now on treatment, develops a stroke and also has subsequent major depressive disorder. So now, a few months later, the patient also develops focal seizures. What would be your best anti-seizure medication? Good. 1. All right. So the reason being, you don't want, though carbamazepine is used for focal seizures, this is a patient who's HIV positive and on TB medication. So both metabolized in the liver, you don't want to use carbamazepine in these kind of patients. You don't want to use Keppra would have been very good in post-stroke epilepsy, but again, this patient has major depressive disorder as well. So there's comorbid psychiatric illnesses. You want to avoid that. So lamotrigine overall seems to fit all the boxes, check all the boxes in this. A 70-year-old man with metabolic syndrome and a history of atrial fibrillation now is on rivaroxaban, develops focal seizures. What would you do? What would you give? Keppra, valproate, phenytoin, or carbamazepine. One. Everyone agree with one? Yeah, it is one. And again, it's the same principle. Rivaroxaban, highly metabolized in the liver, so you want to avoid carbamazepine in these patients because you might decrease the efficacy of that. If there wasn't that, then maybe, in our setting, you could start carbamazepine instead. And last one, 25-year-old lady with obesity, with background epilepsy and severe anxiety is being treated with lamotrigine, but has developed catamenial breakthrough seizures. So what could you potentially do? You could add Keppra. She's already on lamotrigine. You could add valproate. You could add clonazepam as an adjunct, or you could increase the lamotrigine. So I think, yeah, this is what we usually do. I mean, we touched on it in the previous slides, but you'd rather just use a short-acting agent during their period, their menstrual cycle. Usually it's the first 14 days because that's when estrogen goes highest. And then progesterone goes higher after that. So you've got that neuroprotective effect anyway. So in those situations, you just want to use a short dose of a benzodiazepine like clonazepam. Thank you very much. I hope that was much.